There's been some amazing discussion, amazing thought today, and I want to bring it back to three things. I want to bring it back to patients, to the front line of healthcare, and to the next generation of learners who are going to be radically affected by this. So if you're on Twitter today, you can find me there. I've been there somewhat today, but here I am. The AMS is one of the sponsors of this conference. Gail Peach is here, the CEO, and Jocelyn Bennett. And the AMS is about to bring out a book called Without Compassion, There Is No Healthcare, a book that imagines a future in which efficiency, science, and automation serve rather than subsume the ends of human connection and well-being. So a lot of what I'm talking about today draws on this book. I'd like to introduce some real people. We've talked a lot of wonderful abstractions, ethical principles. So you're drinking my water, aren't you? I don't have Ebola, it's okay, but we can share. I'm happy to share, absolutely happy to share. Someone get her a glass of water. Yeah. So there's a lot of important principles and concepts and theory and framework, but I wanted to share with you something different today. I wanted to give you some real people. These are people living with AI. It sort of sounds like people living with AIDS when I was in the 80s, but people living with AI and all different people who are affected by it, and I'm going to talk to you through each of these cases, and one of them is in the room. I hope she doesn't mind me using her. And a sixth figure, which is the AI itself. So the leader first. This is Dr. Heather Ross. She's the Chief of Cardiology at Toronto General Hospital. Heather is an outstanding clinician, a very well-known cardiologist, and also happens to be very interested in AI. And I want to illustrate some of the things that she's doing that point the way toward what leaders in health systems need to be thinking about. Yes, sure, AI can read an ECG. That's actually not surprising or revolutionary to any of us. In fact, when I was in medical school in the 1980s, the machine already did a rudimentary printout of ECG interpretation. What is more important, I think, for us in the clinical setting is not so much the pattern recognition. While that's cool and it's getting better, it's fine, it's accepted. What is more important is actually prediction. Prediction goes closer to the heart of what we do as health professionals. This little study informs much of what Heather is doing. This is from the journal Radiology, and it's about prediction in congestive heart failure. So when your heart is failing, you have a decreased life expectancy. Heart failure is a major condition in Canada, and in this study, they gave an AI system all of the information about patients, the scans, the cardiac cath, stress test, blood results, and it read 8 years of chart data. The AI-driven deep learning system predicted survival rate with 80% accuracy, while the cardiologists were only able to be accurate 60%. This is more revolutionary for us as physicians because it touches on the heart of what we do, the communication about life expectancy to a patient. And yet you can see how important that is for patients. So for somebody like Heather, who's working on a system called Medley, this is an AI-enabled system already in use. It's a practical application where people with wearables and Bluetooth-enabled things monitoring their data at home, this information is sent regularly every day to the hospital where they can be monitored in the community, and it helps to treat and monitor patients. So I use this as an example of something that already exists. It's not a maybe in the future. This is already there. You can sign up for it if you have congestive heart failure or other diseases. But what it raises a question for us is, what should Heather be doing to help her colleagues, to help the system transform itself, to make this realistic and useful? It's obvious that the delivery systems will be modified. They have to be modified. But changing clinician practice is a very steep curve. You can't just drop a new technology in and hope that we suddenly start monitoring congestive heart failure patients in the community where they used to come to the big H to be admitted to hospital. That doesn't happen overnight. And sadly, continuing education is a huge gap. Almost no healthcare institutions have robust continuing education platforms. So all of this change has to be predicated on investing a lot of time, effort, and money into systems of education so that the users of these systems can learn how to use them. And of course, taking the compassionate side, people like Heather Ross have to think about how to not only enhance better outcomes, but make sure those better outcomes include enhancing the relationship at the same time. This is Nikki Woods. Nikki is a scientist teacher. She's the new scientific director of our Research Institute for Healthcare Education. Nikki studies the process of learning and the process of education. So Nikki has a 6-year-old son. This is not her son, but this is a picture from the web, and you can go and look up kids learning from Alexa. And in this case, this video, this kid sneaks into a room, talks to Alexa to do his homework, and says, "Alexa, what's 5 minus 3?" And it's pretty funny. But Nikki's son did something really interesting recently, which got her thinking about what she needs to do to prepare the next generation of students. And that is, it was Easter. And her son, who's 6, said to her, "Mom, what is Easter?" And she said, "Well, in the Christian faith, Easter is when Jesus Christ died, and on the 3rd day he was resurrected." And he said, "Mom, Jesus is dead?" And she said, "Yes." And he said, "Just a second." And he ran in the next room and he said, "Alexa, is Jesus dead?" And Alexa gave the birth and death dates for Jesus Christ. But in here is something critically important at the front line, and that's an issue of trust. But not just he trusts his mother, but he's looking for information from Alexa more than he's looking from his mother. This has very big implications for us as health professionals, right? Because these devices are now available. You all have them. You've been using them all day. It starts to raise questions about when we will consult the health professional and when we'll go right to the device. This is the most disruptive piece that we haven't much talked about today. And we have to grapple with that because that's coming very quickly. These are the top questions to Google around the world. What time is it? Presumably in English. How to lose weight. Number 16 is how to get pregnant. That's amazing to me. I don't know, my faith in humankind is dropping quickly when I saw this. You know, why is the sky blue? Okay, 95, how to get rid of acne. That's the first medical problem, by the way, on the list. And then how to be happy as a psychiatrist. I thought that was interesting. But clearly, we're seeking information of all kinds from the web. And it's not just patients. It's not just rogue patients, you know, looking up stuff on the web like, this is a very paternalistic medical view. It's my students. They come to class and they've done all their homework by looking stuff up on Wikipedia and Google, and right? They do. Medical students, nursing students. So this is overused now. It's the meme. Yeah, we know that AI confuses things. It's peculiar that AI might confuse a chihuahua with a blueberry muffin. A 6-year-old child would not make that mistake. So this is really critical, but perhaps a little bit overplayed. But the kind of confusions that a scientist like Nikki wants to understand are beyond this. Now, what does this have to do with compassion? I think that compassionate care, forever and ever, we've had some interesting debate about the 2,000-year history of medicine, has something to do with being understood. The process of understanding another human being, of listening to them, has something to do with compassion. And we don't want to lose that. Just getting to the right diagnosis is not the same as understanding a person. My function as a doctor is not just to come up with a diagnosis. So if the system that's automated, whether it's Alexa or Siri or whatever it is, has some room for confusion, we have to be careful because the information it returns to patients may have something to do with that being understood. This is a more elaborate example of what we face, and you probably pass through these every day. When you travel, they're getting more and more common. I don't think in Canada they're widely used, but 2 days ago I passed through one on the way back from Amsterdam, and it's the security at the airport where there's no people. It does a facial recognition scan, but what is it looking for? You tell me. What is the algorithm and the AI deep learning system looking for here? Does anybody know? It's looking for something. Matching to people, but it's also looking for this. It's looking for facial expressions that might indicate unusual anxiety, fear, and one of the main things it looks for is not making eye contact, the aversion of eye contact. Why? Because eye contact indicates what? Hiding something, right? Because it's always good to make eye contact. First thing that we tell our students is it's always good to make eye contact. Is that right? An algorithm that's going to make sure you make eye contact? Well, until it's not right. On the left is the science of eye contact in children on the autistic spectrum, in which making eye contact is not a good idea. And on the right is Canada's Indigenous population, for whom making eye contact is like inappropriate physical touching. So This gets us back to the bias topic we've been looking at today, but we need to understand how a system is helping us interpret things. And this set of literature, which I'm recommending more and more, I don't think these have been mentioned today, but to my colleagues to read. Algorithms of Oppression opens with a scary and simple example of Googling black women are and white women are. Simple. The story of this is that Google rapidly modified their algorithms after this book appeared. Very, very interesting. I'll tell you what, how many of you read this book? Have you read it? Yeah. I mean, to not spoil the punchline, but one of those searches returned Ivy League schools and beauty parlors, and the other returned a lot of pornography. So algorithms in the internet are based on previous searches and previous information, so reality becoming shaped. All this to say, the next generation of health professionals need to understand that computers and humans excel in pattern recognition, but in different ways, in completely different ways. So just like the last couple of decades has focused on great work in books such as How Doctors Think, which is about explaining the cognitive processes and errors that humans make, we need our graduates to understand the errors that these systems can make as well. But I think what you've really talked about all day today is that we're going to have to design curriculum. And I didn't hear too many suggestions of what that curriculum looks like. But for those of you in this university, I guess I would encourage you to begin to think how the Faculty of Medicine here is teaching students about law and ethics. Maybe you're doing that already. Are you, Colleen?
No.
Okay. So given that it's fairly widely assumed that health professionals will be responsible for understanding the power and limits of technologies and deploying them, this wonderful conversation you had today somehow needs to be available to those of us who are training people at the front line for the next generation. The third character, the doctor. This is Eric Horlick. Eric is the chief of our medical staff. And what is he doing? He's touching a patient. This is really critical, and maybe more critical than some of us really appreciate. I'm a psychiatrist, and I touch my patients. You're careful in a room of lawyers how you express that sentiment. But touch has for centuries been the core of caring in the health professions. And how did we do that? We did that through something that people will tell you it's not very effective now. It's called the physical exam. It's true, it's not, but I knew that already in '86 when I trained. The physical exam is really not about detecting symptoms, frankly. It's about making a physical connection with the patient. But this is disappearing quickly. It's disappearing quickly. When I had a ruptured appendix, I went to I didn't know it was. Well, I did, actually. I had acute abdominal pain. I went to Toronto General Hospital. They sent me to the radiology department, and the doctor came back and said, the CT scanner says you have a perforated appendix. Not my hand on your abdomen. And so the gap has been growing and growing and growing. And this is something that wasn't mentioned hardly at all today, but we have to talk about, which is, although the electronic patient record is not AI in and of itself, it is the biggest source of huge amounts of data that will feed AI. And if you go around and ask doctors and nurses what they think about the electronic health records, you're going to hear a wide range of opinions. You went live this morning at 5. Congratulations, and condolences. Because spending time on an electronic patient record is a direct challenge to the connection with patients. The use of this has multiplied by hours and hours a day, and it's now considered to be one of the main causes for the separation, the loss of the human contact between doctors and patients and nurses and each other. You may have seen Gawandi's article, Why Doctors Hate Their Computers, and I think if we're going to get very excited about AI, that's all fine, that's great, lots of promise, but who is going to be entering the data, and how is that going to work, and what is the interface like? And that's a subject that's really critical, because electronic patient records also theoretically can, and do to some degree, improve quality and safety and outcomes and all the things we've talked about today, except people really hate them, generally speaking. And by the way, they're causing burnout. So what is the interface of the technology? What is its ecological function when it's taken up into practice? Now, I'm very intrigued by something that did come up this morning and last night, actually, and I think, speaking for those of us kind of at the front line, we would actually appreciate a little more work on this, is when will it be unacceptable not to use AI? And I'm going to give you an example because I think now there is one, although it's not written down anywhere, I don't think. Maybe someone with a legal mind has encountered this, but this is drug interactions. It's been true for quite some time now that the human brain of a clinician cannot calculate out the combinations and permutations of drugs. So when a patient comes to you, this is pretty typical, with the medications that they're on, we cannot do that. A human mind cannot do that. I'm going to advance the hypothesis that it is, as of now, or as of probably 10 years ago, incompetent not to use a system that can calculate those interactions and try to monitor drug interactions without an automated system. So I think we would benefit as well by starting to think, what are the ways in which we really should be improving practice? And separate the wheat from the chaff here. Separate out some of the sparkly future things that have potential from those things that we already know right now can improve practice. I'm with Colleen on this, that there are some things that we should just embed in practice right now. So in this area, we really need to think about education, that it helps us adapt technology to the practice environment, but seen through the lens of compassion, not just compassion for patients, but compassion for those people who work in the system, who, by the way, right now have catastrophic levels of burnout. So we already know that there's quite a strong association between some technologies and burnout. So I think what we have to start to do is focus on how the technologies can be deployed in ways that reduce burnout. And while I'm raining on the parade of electronic patient records, the vendors finally are responding to clinicians and they're answering questions. We're going through our own procurement and we put to every company, what are you doing about the problem of the interface and how it affects people who use it every day? And there are innovative ways coming. By the way, natural voice processing, recognition, and combined with auto text creation is one of those things. And so there are ways that AI may be able to assist to that. But I think that those of us who are in leadership positions have to also make sure we're evaluating the technologies for their impact on the well-being of people in the system. The fourth player, and in some ways the most important, is patients. I don't know if you invited patients to this conference today. It's become a usual thing for us in healthcare to have patient partners at every table and every meeting, and I think it's something I would highly recommend. Maybe you do this in your bioethics councils or in some of your legal programs, but I think it's something to be encouraged in conferences as well. This is Judith John. She's a wonderfully articulate patient partner. And she's spoken, you can see here for the government, Health Quality Ontario, but she's spoken very, very widely. But Judith, I think, illustrates another angle, dimension to this that we really have to think about. How does it, in fact, affect patients? Largely today, I've heard a lot of discussion about how it improves patient outcome, and that's critical. But what about patient experience? What about what it's like to be a patient in an increasingly technical environment? And Judith's story is pretty bracing. She has a benign brain tumor that's wrapped around her optic chiasm, which can at any moment cause her to lose her vision. So she has regular radiation. It's not malignant. She's not going to die from it, but it's something that requires a pretty drastic treatment, radiation therapy. So when Judith goes into this situation, can you imagine being in this situation? Has any one of you ever worn one of these masks? This is really something. And this is Judith herself. A picture she chose for the cover of our hospital magazine. She says, I am amazed and impressed and really, I think it's wonderful that we have all of these amazing technologies, but it's as scary as hell, and it's just a horrible thing. And when I'm in that machine, I need a human being. I need someone to look in my eyes. I can't move my head, to hold my hand, and to be with me. I need a human health professional to do that. And I think that's always going to be true. Eric Topol's book has been mentioned a few times, and it's called How AI Will Make Healthcare Human Again. But how many of you read the Topol book? You got to get all the way to the last chapter to find out how it's purportedly going to make healthcare human again, because most of the rest of it is applications of AI, which is very interesting. But when you get to the end, you get to this quote. The super streamlined workflow that lies before us, affecting every aspect of healthcare as we know it today in one way or another, could be used in two very different ways to make things much better or far worse. And what he says is the difference between much better and far worse is the gift of time. If AI makes healthcare much more efficient and saves time and automates, and then we choose to reinvest that time in better patient experience, it will be much better. That's the caveat. And Abraham Verghese, who wrote the wonderful introduction, echoes the same thing and says this is actually high risk, folks. It's automation. Much of the use of AI is about automation. And automation is great, but what are you going to do with the found time? So this points to something that leaders must do very aggressively, which is try to harvest the found time to invest back in proper, better patient care. So technologies are introducing a distance between providers and patients, and that distance can become a threat to compassion. So we really need to be aware of this distance and find ways to foster our presence, including wise use of the gift of time for people like Judith when they're benefiting from highly technical environments. And here's Caitlin Gillen. Caitlin is, I've called the learner. Now, Caitlin is sitting here. Caitlin is a very accomplished person. She's a radiation therapist. She has a master's degree. She's in practice. Why am I calling her learner? For two reasons. One is we're all learners, especially in this area, but she's chosen to go back and do something that very few people have, which is a PhD to understand how her own professional area is being transformed. There are very precious few people right now in the health professions actually studying how it's going to change our practice. Most of the eyes are from outside. And this is something, forgive me, you can correct me after how well I do with this, but Caitlin, radiation therapists do what's called radiation treatment planning. So when Judith comes to have her radiation, a team of people has to figure out how to safely and carefully calibrate the machines to deliver that dose. This is a dangerous procedure. Until April of last year, our treatment planning process that people like Caitlin undertook was about 4 hours per patient. And then the AI system was installed, and it became 3 minutes. So 175 treatment planners, radiation therapists work at Princess Margaret Hospital in Toronto, 175. And one of their main tasks has just gone from 4 hours to 3 minutes. That is not a maybe. That is a real thing. And so I can see why we need a PhD urgently about the effects of this. And here's one of Caitlin's first papers looking at this, and she's taking a really interesting look at how the regulatory colleges, the professional associations, and others are going to respond to this. But we have to understand this. But I want to give you a sobering example of why this is so important. Does anybody know what this is? Does anyone in the room know? Yeah, Jocelyn. None of the rest of you? This is a very cautionary tale. You can get a hint from the look of that computer. The Therac 25 was involved at least 6 accidents between 85 and 87 in which patients were given massive overdoses of radiation, hundreds of times the therapeutic dose. They were burnt to death in the United States and Canada. This accident highlighted the dangers of software control of safety-critical systems and have become a standard case study in health informatics and software engineering. It's interesting nobody knows about this case. So what is the implication of this for a radiation therapist today? I would invite you to consider a more recent example. This is the Boeing 737 MAX, which crashed because of a software problem in a black box that nobody knew how to fix. Oh, except for the people that had simulator training. Do you know that the only airline in North America that actually owns a Boeing 737 MAX simulator is Air Canada? And the big fight right now to get these planes flying again is whether they're going to, the Transport Association is going to require simulator training. If they do, this Air Canada simulator is going to have a lot of use, and those planes aren't going to fly for a long time. And it sheds light on the fact that as educators, we can't just adopt new technologies without a whole lot of practice to use them. And so this is the school that I look after called the Michener Institute, where we train radiation therapists. And the system there actually builds in the Therac mistake into the software in simulation so students can experience it. And this is an element of teaching and training that we haven't talked about today, which is I don't think patients want us to experience or practice new technologies for the first time on real patients. We really have to think about an infrastructure to practice it in simulation. So adapting education for this area, this new area, or emerging area of human-machine collaboration is going to be critical with practice and simulation, opportunities to meld human psychomotor skills with machine guidance, but critically remembering that we're human and that we have emotions. And when a machine fails or we're tired, things can go wrong. An emerging literature is on something called tech rage. And tech rage is a really interesting phenomenon. I get a little bit of it every once in a while. I was in Hong Kong giving a lecture like this. There were about 2,000 people in the audience. I stood up very, very formal, ready to go. And up on my computer comes a message that says, please wait, rebooting, virus program's loading. I'm like, oh, God, really? You kidding me? And so thinking quickly, I used it as an example to talk about my own emotional reaction and how this happens regularly and we have to learn to control it. But can you imagine if Caitlin's running the radiation therapy machine and Judith John, and you're holding her hand and everything's ready to go, and all of a sudden the machine crashes? Are we prepared for that? Very important. Who takes over when the AI stops working? Who takes over when the power goes out? And lastly, our new colleague. And I've stolen this totally from Caitlin's work. I think she gave a lovely talk a couple weeks ago at a conference on AI and proposed that we maybe think of AI the way we think about interprofessional education. So we have a team with various colleagues on it, doctors, nurses, physios, bioethicists, lawyers, and maybe now AI. But there's a romantic version of this, and most of us, well, not all of you, but I grew up with this. So people who are really old grew up with some version of the doctor, the holographic doctor. I don't think this image serves us too well. Conceptually, it serves us well, but I think we have to appreciate that what AI is going to look like on our team is more like this. This is the dementia seal. And if you're like me, you're going to get mixed reactions to this. If you have relatives like I do who have dementia, you're going to know how very little we do in the healthcare system for patients with dementia. And you're going to think, maybe it would be nice to provide something. But a part of you is also going to think, wow, but shouldn't that be a human being? You're going to have mixed feelings. But I think we can be thoughtful about the judicious use of AI as a team collaborator. And this is Ludwig. Ludwig is actually named for Ludwig Wittgenstein, the semiotic expert in Germany. This is a dementia device that helps detect verbal patterns that suggest deteriorating cognitive function. And this is a robot which has been showing some effectiveness in the activation of dementia patients with behavioral problems. So I think while it's fine to think about the Star Trek doctor, I think what we want to think about is more expansively what AI might look like as a collaborator. Just going to end with a couple quotes. In writing the book, we became aware of this dichotomy. The Bill Gates quote is that technology is unlocking the innate compassion we have for our fellow human beings. But the Dalai Lama said, well, I think technology has increased human ability, but technology can never produce compassion. Our view at AMS is that this is a false dichotomy. It's not humans good, technology bad. And the book really focuses on this, and it's the last quote I'll leave you with. And I might in some ways sum up the day. In order to understand what kinds of work humans will be needed to do, we first need to acknowledge that humans and technologies are not opponents. Together, they create an urgent need for compassion, but only together are they likely to address that need. So thank you very much.
So that was an incredible talk, and I'm going to, without further ado, pass it over to Nicolas.
Yeah, follow that. So this is, congratulations, that was great. And this is a great opportunity for me because I'm intensely interested in the impact of AI healthcare and robots on empathy. This is an intensely human trait, referring to the ability to understand, feel, or share the feelings of another. It embodies quintessentially human values such as compassion, responsiveness, patient-centeredness, equity, and trust. These are also traits and values that are important to patients. These are also instrumental with great value to the healthcare providers because, as acknowledged by Beecham and Childress, good healthcare often involves insight into the needs of patients and considerable attentiveness to their circumstances, which may derive more from emotional or sympathetic responsiveness than for reason.
Active compassion.
This is active compassion. You are a good man. Shall I start again? No. So, empathy may well be too important a property in the diagnostic, treatment, and recovery processes to abandon. To stretch an analogy, robots that can grill meat, slice tomatoes, stir-fry vegetables, and even stretch pizza dough are making fast food even faster. But would you trust a chef who has never tasted the food it creates? Empathy also goes beyond a caring imperative to a protective one. According to Pellegrini, it's important to consider patients' vulnerability in the relationship. For physicians to fulfill their commitment to trust, they must protect rather than exploit the vulnerability. So as we design and regulate healthcare AI, we have to address the extent we believe they should be subject to ethical rules and to an extent be infused with human values. This is both a technical question, whether our caregiver and other healthcare technologies can be effectively programmed to approximate the empathetic needs and expectations of patients, and also a normative one. As the latter, do we want our technologies to fake it? The analogy, once again, can be drawn to pure electric automobiles. The quietness of the driving experience has led some manufacturers to create artificial engine noise that is piped into the cabin. I turned mine off. However, automobile noise is more than a matter of taste. From September 2020, hybrid and electric vehicles sold in the US face minimum sound requirements during low-speed operation to alert pedestrians, particularly blind ones and cyclists, in the presence of such vehicles. A similar rule is being implemented in the EU. If you want an example of faking it, you're all on devices here and not listening to me anyway. Go to YouTube, and I think you need to sort of Google end of life care robot or something, and you will see the creepiest thing you have ever seen. It's a proof of concept as a robot strokes a patient's hand, telling the allegedly dying person that she's there instead of her family, but they really wanted to be there. It's awesome. Now, not all of our concerns about empathy or compassion will be raised by all types of AI. If we look at AI as substituting for some parts of the healthcare value chain, then at one end, substitution is highly likely in areas where humans are unavailable or unwilling to work, or where it's too dangerous. So we'll see automation of drudgery, the disinfecting of rooms, the disposal of surgical waste, and empathy may not be directly implicated by those tasks. At the other end of the scale, substitution by AI is likely when problems are identified as prediction problems. Currently, medicine, and so maybe medical education, approaches its prediction problems with a combination of heuristics and rule-based models. The former can suffer from cognitive biases, such as availability and confirmation bias, and the latter rule-based models found in clinical practice guidelines or clinical decision practice systems are relatively blunt tools that create alert fatigue and have their own error profiles. Properly trained AI inevitably will take over this space: pathology, radiology, diagnosis, and so on. Now, if we accept that proposition, even for the sake of argument, as the day comes to an end, then I think medical education has some interesting challenges. And I'll give you 5. I think it's 5. 1, clinicians will have to learn or relearn to work in teams. Not this time with other humans, such as nurse practitioners, but with AI. 2, medical education may have to address the very difficult question that the clinician may no longer be the ultimate decision maker. 3, AI, algorithmic decision making, increasingly will be opaque. Clinicians will have to be trained not only to understand them as best they can, but also to interpret the AI decisions for patients, an increasingly difficult problem with AI. As AI takes on more of the scientific decision-making, doctors must be taught to avoid becoming part of the technocracy, to be increasingly protective of the vulnerable, and take responsibility for the maintenance of empathy. And finally, you may need to admit smaller classes.
The very narrow task of being the steward of getting you out of here before 5 o'clock. So I'm going to make sure that if anyone wants to come to the microphone to ask questions, this is your time. But what I might just leave you with for that transition is, what are the must-haves and what are the nice-to-haves and what are the cannot-haves? So I think of things in 3. It's by training. I always end up there. But I think the entire day we've started to carve out where are the no-go zones, where are, we heard, drug interactions might be the areas where we must have it. And I think the question marks are where it's the nice to have. Where is it actually replacing things that enhance, is the place where that enhances the patient experience or it's essential to the patient experience? Do those fall into the we cannot have it, or is that a nice to have? So I'll just leave you with that, but I see we've got someone at the microphone already. Antonia.
One quick question that I think ties this presentation, which is wonderful, thank you, Dr. Hodges, to some of the conversations we were having earlier, which is we were talking about how AI is a problem, is a challenge because of the distribution of scarce resources, right? We've heard that argument, and how do we ensure that all patients get the benefit of AI? You know what? You've just turned that, I've been thinking about how you also turn that on its head and say, well, maybe in a future not that far away, it's only some patients who will have actually the benefit of that close personal contact with the empathetic human being. And that's sort of scary stuff. So I was wondering if you could also just comment on that.
Yeah, you may have seen the Prediction Machine book by this book highlights machine failure. A little green.
Just takes a minute to queue up.
I can predict. I'll keep predicting until it comes up. So in Prediction Machine,
I don't have sound from my answer.
I think this is simply
it's the Therac 25. In the Prediction Machines book, how many of you read Prediction Machines? Yeah, a few of you. Yeah, it's an interesting book. It's written from an economic perspective, and I think where did you go? Just question asker. Right here. I think you may have a point, and I think we do need to think about this, because what the economics would suggest is that things that become easier get cheaper. Now, to Colleen's point, we're not going to pay $800,000 to a radiologist if a machine can diagnose an X-ray and the radiologist is simply reading those X-rays. The wiggle room here is that services that are rare or cannot be provided by AI will continue to be sought out and continue to be valuable. So I think there is a future, which you're alluding to, in which some human-based services become rare and are therefore expensive. And the question will be how to distribute those equitably. We already have a bit of that in my field of psychiatry. Look how hard it is to access a psychiatrist, for example. But this could become more acute. The chances of you ever seeing a live, let's leave radiology alone because they're kind of abused, but a cardiologist, an actual live human cardiologist is likely to become very rare.
So I'm seeing Colleen is running to the microphone.
Well,
so-
running is a bit of an overstatement. Just thinking about that and Antonia's question, I think though it's, again, through this whole day we're sort of searching for answers, and often in law we're looking for a rule or a regulation or a law, and that's very tricky when we have such a heterogeneous kind of pool of things that we're talking about. So there's a huge variety of what AI will manifest itself in healthcare. And so on that particular issue of the warm human touch, I mean, it doesn't have to come from an $800,000 a year physician. It could come from just a really nice person, maybe even nicer than what we presently get, who's trained to be nice. That's their job, and to help the patients navigate this world of machines. So maybe new kinds of providers. So I'm not saying that's the perfect answer to your concern, or Brian's concern, but it's maybe part of the answer. And I think another piece there that I've seen some evidence that I think NASA had some avatar that they were using for PTSD treatment, and that the avatar was actually more successful than the psychologist because people were more honest, ironically, with the avatar about their drug use and their addictions. They didn't feel the judgment of another human, even although they must have known ultimately it would be read by a human, but somehow in that encounter they were able to be more honest. And I'm not saying this is a complete answer, it's just that I think it's very complicated, and the answer depends on the technology and the use that it's being employed and the context in which it is in. And so I think this kind of desire for us to solve everything in one caboodle, we can't. We've got to sort of segment it out and figure out the complexities and answer these problems as we go along.
Colleen, I totally agree with you, actually. I'm not scared by this. I think, again, careful not to fall into the romanticism, humans good and machines bad. I think if you start with and this was mentioned earlier, but a simple principle, which is what's going to lead to the best outcome for patients. We really need to be patient-focused and really start with that. So one of the things that is almost certain to be disrupted is what we call scopes of practice. We cling on to these. I'll give you a really simple example that I don't think will last more than a couple of years, and it's going to be tectonic. So very quickly, because I know the time, imagine that you have detected a lump. Let's use a woman with a breast lump, man with a testicular lump. So you will go and have a biopsy, and that will be fed into a laboratory system, and then you'll have imaging in a different department, in a different part of the hospital, with a different staff today. But when that's all integrated in AI, as we've just done, we've just merged our laboratory and imaging departments because the AI system doesn't care if the picture is of a biopsy or an X-ray. Those are old distinctions based on old professional identity. Before your feet hit the ground in the imaging suite, the AI will have already calculated the probability combining the lab results and the image, and will know or be able to tell someone the differential diagnosis and probability that that is a malignant tumor or a benign tumor. And what do we do today? Go home and wait, and we'll make an appointment for you in 3 weeks to come back and see the doctor. I'm predicting, this scares my colleagues, but the physician's exclusive right to communicate a diagnosis is not going to survive this era. Because I think what we will have is a system rather where other health professionals are authorized to communicate probabilities generated by an AI system. They're probably interpreted, the plan of action helped with a health professional like a physician. But I think this is one that's pretty obvious to me, that the exclusive monopoly on the communication of a diagnosis can only be done by a physician. I cannot imagine that this is going to survive more than a few years, but it's going to be a real struggle, and it's a very tectonic change. So back to is this incremental change or real change? That is a very big change of 2,000 years of history of medical practice.
Well, and I think it's that triage function that we've talked about a few times today, where machines have an incredible ability to facilitate more effective, more efficient care, at the same time as, if we don't want to layer and make things more expensive, but at the same time acknowledge that there's going to need to be a bit of a revolution from a regulatory perspective to allow for those different scopes of practice. I think this is where lawyers, bioethicists and clinicians are all going to continue to need to come together in the way that we have over the last day and a half in order to wrestle with these conversations, come up with some practical solutions, as I know that we've heard today, and continue to have these sort of brain expanding conversations that we've also had over the last couple of days. So I'm hoping that I have taken us to exactly 5 o'clock. Thank you so much for the incredible talk, for the enlightening, invigorating dialogue that we've had today. And thank you especially to the organizers for hosting us.